Today we are going to see the new topic, uh, which is basically on post-exposure prophylaxis for HIV. As per National AIDS Control Society's current norms, we are going to see what are the current norms of post-exposure prophylaxis for HIV. Objectives of today's sessions. Uh, by the end of the session, participant will be able to understand the risk of transmission of HIV through occupational exposure, first aid after the occupational exposure, counseling for the persons reporting occupational exposure, prescription of the PEP drugs and follow-up procedures, prevention of occupational exposure, uh, pre- documentation of occupational exposure reported. Moving toward the definition, post-exposure prophylaxis refer to the comprehensive management instituted to minimize the risk of infection following potential exposure to blood-borne pathogen. It is not confined to only HIV. Uh, it include HIV, hepatitis B, and hepatitis C, like blood-borne pathogens. PEP is the standard protocol for preventing chances of getting HIV infection when healthcare worker or healthcare provider is exposed to the uh, source patient known to be possibly HIV infected. That is known as occupational exposure. NACO guideline describes the risk of infection, the preventive measures, step followed to deal with the accidental occupational exposure to HIV and other bloodborne pathogens. The post-exposure management protocol is important element of workplace safety. Type of exposures: exposure which may place a healthcare provider or healthcare worker at the risk of bloodborne infection is defined as a percutaneous type of injury, contact with the mucous membrane of eye, mouth, or nose, contact with the non-intact skin, uh, prolonged contact of the intact skin with the blood or other potential infectious fluid, occupational exposure, exposure to the potential bloodborne infections during the performance of duty. Non-occupational refers to exposure to the bloodborne infections outside the workplace setting, like unsafe sexual practices or sexual assault. Now, categories of exposure. There are three types of categories of exposure: mild exposure, moderate exposure, and severe exposure. Uh, by definition, mild exposure means exposure to mucous membrane oblique non-intact skin with small volume blood, contact with the eyes, mucous membrane, or subcutaneous injections following small bore needles. Moderate type of exposure is defined as exposure to mucous membrane with large volume of blood or percutaneous superficial exposure with the solid needle. Uh, for example, superficial cut or needle stick injury penetrating the gloves. Per- Severe exposure, percutaneous exposure with the large volume, uh, an accident with the high caliber needle, more than 18 gauge, visibly contaminated with blood, deep wound, that is hemorrhagic wound, very painful, transmission of significant volume of blood, and accident with the material that has previously been used intravenously or intra-arterially is considered as a severe type of exposure. Note that wearing the gloves is one of the standard work precaution, but gloves puncture do happen. In case of accidental exposure with the material, such as discarded sharps, needles, dyed contaminated blood, transmission risk remains for a week for HIV, and the risk remains more significant for hepatitis B, C, as they survive longer than HIV outside the body. This is important point where most of the time when exposure occurs to the discarded sharps and needles, at that time you have to consider that uh, comparatively higher risk in case of hepatitis B and hepatitis C. Uh, but HIV, still there is a risk for a 1 week. These are the mainly risk of exposure from different body fluids. This slide explains the risk of exposure from the different body fluids. Exposure to the body fluids considered as risk: blood, semen, vaginal secretion, cerebrospinal fluid, synovial fluid, peritoneal, pericardial, amniotic, and other body fluids contaminated with visible blood. In case of Others like tears, sweat, urine, feces, saliva, sputum, omitus, they are not considered as a body fluid which having risk of exposure. Mm, They are exposure to body fluids considered not risk until unless they contain visible blood. If they contain the visible blood, tears, sweat, urine, feces, saliva, sputum also categorized into the uh, body fluid which having risk. Now moving towards this next slide, which shows us HIV transmission risk by different routes. Blood transfusion near about 100% or more than 98% risk of transmission of HIV when contaminated blood or HIV infected blood is directly transmitted. That part is not occurring currently because all blood banks screening the blood before giving for transfusion uh, for HIV, syphilis, hepatitis B, hepatitis C, malaria, as per NACO norms. Mother to child transmission, near about 20 to 40% rate of when mother is infected with HIV. Uh, Without any intervention, there are chances of near about 20 to 40% to transmit the infection to the child. By sexual intercourse, when uninfected person has sexual intercourse with the infected person, at that moment there are chances of 0.1 to 1%. Uh, these chances are further divided into depending on different type of routes of sexual intercourse, vaginal, anal, oral. In case of injecting drug use, near about 0.67% chances of transmission of HIV. And injecting drug use mainly affect the eastern part of the India, where this percentage is considerably high. Uh, when we talk about the occupational exposure, we have to focus on only these two routes: needle stick exposure and mucous membrane flash to eye or oronasal mucosa. In case of needle stick exposure, there are chances of 0.3%. In case of mucous membrane flash to eye or oronasal mucosa, at that moment risk is 0.09%. Comparative risk after needle stick injury, uh, there is a rule of 30, rule of 3. In case of hepatitis B, 30% chances of transmitting infection from infected person to uninfected or exposed person. Then in case of hepatitis C, that risk is approximately 3%, and HIV is 0.3%. You can remember in that sense also. Now moving toward the management of exposed person, there are six important steps while managing the occupational exposure to the infected blood. First management of exposure is first aid. Then second step is establish the eligibility for post-exposure prophylaxis. Third one is most important step, which uh, play crucial part is counseling of for post-exposure prophylaxis. Third one, fourth one, assessing the need of PEP and prescribing post-exposure prophylaxis. And fifth one is laboratory evaluation uh, of the patient; those were put on the post-exposure prophylaxis. Last one is follow-up. First step, one by one, we are going to see the all six steps in a management of post-exposure prophylaxis. First one, management of exposure. Skin, if the skin is pierced by the needle or sharp instrument, do not put the injured finger into the mouth in reflex action. Immediately wash the wound and surrounding skin with soap and water and rinse. Do not rub the area. Do not use the antiseptic solutions. Or skin wash. Do not use the bleach, chlorine, alcohol like disinfectant. Consult with the designated physician of the institute for management of exposure immediately. In case of any medical institute, there should be a post-exposure prophylaxis management committee, and nodal person of that management committee, the nodal officer of ART center, if that institute has the ART center. And second most important part is in that committee, ICTC or ARTC counselor plays important role, and reporting of the exposure should be in a first contact of reporting must be a counselor one. A counselor, uh, exposed person has to contact the counselor or nodal person of the post-exposure prophylaxis committee, and that nodal person, often physician or MD medicine, uh, who um, or if nodal person is not available, if ART center is present in a medical college, then at that moment, senior medical officer of ART center is the right person to which exposed person must immediately contact after the exposure. Now, management of exposure to mucous membrane, mainly eyes and mouth. In case of eyes, irrigate the exposed eye immediately with water and normal saline. Uh, Tilt the head back. Ask the colleague to gently pour the water or normal saline over the eye. If wearing the contact lenses, leave them in a place. Do not remove the contact lenses as they form a barrier over the eye and help to protect. Remove the contact lenses and clean them in a normal manner. This will make them safe to wear again. Do not use soap or disinfectant on the eye. Consult with a designated physician. Then, in case of exposure to the mouth, usually it happen in a lab, but nowadays mouth pipetting is totally obsolete. So chances of exposure to mouth is minimum. Uh, if exposure occur, rinse the mouth thoroughly using water and saline. Repeat the process several times. Do not use soap, disinfectant in the mouth. Consult with the designated physician immediately. Now, establishing eligibility. This is the most important step, and that decision or establishing eligibility is uh, responsibility of nodal person or post-exposure prophylaxis committee or the in charge of ART center. Uh, the decision of the need of PEP for HIV following the occupational exposure in a healthcare provider will depend on the type of exposure and source HIV cases and the extent of disease. The source has been confirmed HIV positive. It is decided based on the exposure code and source code. So, what is meant by exposure code? Whether the material, blood, body fluid, or other potentially infected material or instrument contaminated with one of these substance uh, is define the exposure code. If yes, in case of exposure code 1, mucous membrane or skin integrity is compromised. EC1 is small volume, few drops short duration, and exposure code 2, large volume, major splashes, uh, long duration. EC1 is basically mild type of exposure. EC2 is moderate type of exposure. In case of EC3, there is a severe type of exposure, which we learn in earlier slide. See, in case of percutaneous injury, it can classified into two types, mainly depend on which type of needle stick injury occur. When less severe type of injury with a solid needle, like a needle which is used for the stitching or suturing, at that moment or superficial scratch occur, it categorized into the exposure code 2. And in case of more severe type of injury with hollow bore needle, deep injury is categorized into exposure code uh, 3. And intact skin, if exposure occur of body fluids, which is contaminated body fluid, blood, or potentially infected material uh, to intact skin, then it not indicate merely contact with the intact skin of potentially infected body fluid, not indication of for PEP. Now moving toward the what is meant by source code. Source code means basically HIV status and disease condition of the uh, source. If source is HIV negative, then no PEP required. If source is known case HIV positive, then you have to see for whether that source disease clinical status and disease progression. If low titer exposure occur and HIV positive patient is asymptomatic with high CD4 count, then it is categorized as a HIV source code 1. If high titer exposure occur with the patient having advanced disease with low CD4 count, then it is categorized into HIV source code 2. In case of unknown status, most often what happen, uh, sometimes when needle stick injury occurs from the thrash or biomedical waste, at that moment you don't know the status of the patient. Uh, in such a scenario, called as the HIV status unknown. Now, recommendation for PEP for the healthcare personnel based on the exposure type. Uh, this is the brief summary. When exposure code is 1 and source code is 1, means HIV negative patient. Source is HIV negative and exposure code is 1. That is mild type of small volume, few drops for short duration. potentially infected fluid with mucous membrane and skin integrity compromise, and exposure is small volume. At that moment, it is called as exposure code 1, and exposure code 1 and source code 1 not warranted for the PEP. Later on, even though exposure code is 1, if source code is HIV positive 2, at that moment there is a recommendation of post-exposure prophylaxis, and which can be given for the, which is recommended to give for the 28 days. Source code 2, exposure code 2, source code 2, exposure code 2, source code 1, even it required the PEP. Source code 1 is HIV positive. In case of unknown status source code, if exposure code is 2 fall into 2 and 3, in that case you have to consider the local prevalence and give the uh, PEP based on the prevalence, and that PEP should be continued for 28 days. Counseling, third step, the exposed person should receive appropriate information about the post-exposure prophylaxis and the risk and benefits of drugs given in a PEP, and informed consent. It should made clear that PEP is mandatory but needs to be taken. Understand the details of window period, baseline test, drugs that use, their safety efficacy. Be counsel on safe sexual practices till both baseline and 3-month HIV tests are found to be negative. Receive the counseling women regarding use of PEP during the pregnancy and breastfeed. They must receive the psychological support. Many people feel anxious or depressed after exposure. Some may require further specialized psychological support. Uh, be informed about the risk and measure that can be taken to relieve the part of anxiety. In case of exposed person, opt out for the PEP even after intensive counseling should be advised for the testing of HIV, SCV, hepatitis B at baseline, 6 weeks, 12 weeks, and 24 weeks from date of exposure. Documentation on record and timely reporting is the most important part in case of treating or managing exposed person. Key consideration for prescribing PEP should be started as soon as possible, ideally within 2 hours, preferably within 72 hours of exposure based on eligibility assessment. If a healthcare provider present after the 72 hours of exposure, PP can still be used after counseling about its effectiveness. Prophylaxis need to be continued for the 4 weeks. Counseling to be done also by the prescribing doctor, not only counselor. It can be it must be done by the prescribing doctor. In case of sexual assault, PEP should be given to the exposed person as a part of overall package of post sexual assault care. This is the most important line. And such a type of exposure categorized under the non-occupational type of exposure. All pediatric sexual assault cases need to be notified to concern authority, nodal officer in a state as per POSCO Act 2012. Now, moving toward the most important part, that is recommendation, which type of drugs should be we have to prescribe as per NACO. In case of exposed person, when exposed person's weight is more than 10 years and age is more than 10 years and weight is more than 30 kg, at that moment, recommended PEP drug is antiretroviral drug is tenofovir, lamivudine, dolutegravir. It is a fixed dose combination. One tablet, you have to take that tablet OD, preferably in a night after 2 hours uh, after the lunch, after the dinners. Tenofovir, if alternate regime, if preferred regime is not available at that moment, if preferred regime is not available, tenofovir, lamivudine plus protease inhibitor, ritonavir boosted lopinavir can be given, or tenofovir, lamivudine, and efavirenz fixed dose combination TLE can be given if preferred first line regime is not available. In case of children more than 6 years age and weight more than 20 kg, zidovudine, lamivudine, dolutegravir is the preferred post-exposure prophylaxis drug, and mostly it is given in case of sexual assault cases. If hemoglobin of that child is less than 9, at that moment we can't use the zidovudine because zidovudine can cause bone marrow suppression. So preferred choice is abacavir lamivudine plus dolutegravir, one tablet OD, ALDTG. And in case of child less than 6 years and age less than 20 kg, at that moment, if HB is more than 9 gram, at that moment you can give the zidovudine, lamivudine, and dolutegravir combination as per weight band. Then if HB is less than 9, at that moment you have to use the abacavir, lamivudine, and dolutegravir. And dolutegravir can be used as per dosage, as per weight. First dose of PP should be administered immediately within 2 hours, preferably within 72 hours. Healthcare providers should counsel about the safety of the PEP. Duration of PEP is 28 days, regardless of PEP regime. Now, situation that requires the expert opinion. If source HIV status is unknown, PEP is advised on case-to-case basis based on severity of exposure and epidemiological likelihood of HIV transmission, mainly prevalence in that area. When we talk about the India and Maharashtra, at that moment, prevalence of the uh, burden of the HIV in Maharashtra, in all state of the Maharashtra, is considerably high. So, epidemiologically, those who are working in a healthcare institute in the Maharashtra, they has to take the post-exposure prophylaxis for HIV if HIV status of the person is unknown, and severity of exposure code is falling into exposure code 2 and exposure code 3. Do not delay the PEP initiation in case of known or suspected pregnancy. Pregnancy is not a contraindication for the giving post-exposure prophylaxis. Breastfeeding issues in the exposure person. In case of breastfeeding, also you can give the post-exposure prophylaxis. Source of patient is on ART or possibly having drug resistance. Since 2004, ART program is launched, antiretroviral treatment program is launched, and currently we are encountering the drug resistance among the already on ART patient. There are n number of patients having second line ART, some having third line ART. At that moment, in such a cases, expert opinion should be taken, and that expert opinion must more often taken from the SASEP or state referral expert panel. Refer to the expert in case of drug intolerance and in major toxicity and non-compliance or non-adherence or complicated cases. In case of antiretroviral drugs, most of the drugs are having major side effects. In case of tenofovir is passing through the kidney or renal system, and long-term use of tenofovir is resulted to the renal toxicity. If any patient having renal abnormality, at that moment you have to consider about the uh, underlying, if exposed person having underlying renal abnormality, at that moment you have to rechange or reshift the regime TLDTG, tenofovir, lamivudine, dolutegravir, to the alternate antiretroviral therapy. Now moving toward the if source is HIV negative and it positive for the hepatitis B, at that moment you have to know about the which type of prophylaxis is needed for the uh, when healthcare worker is exposed to HIV hepatitis B positive blood. It depends on the vaccination status of the exposed person. If the healthcare worker is never vaccinated, at that moment, recommendation is that you have to give the complete hepatitis B series for the exposed person. If vaccinated, if a healthcare provider which is exposed to hepatitis B positive blood or body fluid, at that moment you have to give the uh, you have to know the antibody titer if the healthcare worker is vaccinated or fully taken the vaccine. If antibody titer is not known, at that moment you have to give the hepatitis B vaccine booster. And vaccinated more than 5 years ago, give the vaccine booster once again. If not, note that if not available testing for the antibody titer is not necessary, hepatitis B vaccine should be given as soon as possible after exposure. Do not wait for the anti-hepatitis B titer if the test is hepatitis surface antigen test anti uh, result is if test is done. Adequate levels of anti hepatitis B surface antibody is more than 10 international unit per liter, and in such a scenario no further vaccination is required. And these are the recent guidelines as per NACO. CDC or ICMR guideline may differ in case of post-exposure prophylaxis of the hepatitis B. And most important note is that when you or a healthcare worker got exposed with the hepatitis C positive patient, there is a patient at that moment there is a no available post-exposure prophylaxis for hepatitis C. Now, fifth part, step fifth, laboratory evaluation. In any healthcare worker who is exposed to the blood-borne pathogens or to the HIV positive blood at that moment, in case of HIV, you have to do the baseline testing. Baseline investigation includes serostatus of the patient, HIV, hepatitis C, hepatitis B surface antigen antibody, surface antigen, a complete blood count, and serum transaminase. Uh, HIV, hepatitis B surface antigen, SCV testing of exposed staff within 6 days of exposure is recommended. If the exposed healthcare worker found positive, uh, it may indicate discontinuation of PEP, and you have to put that patient for the lifelong antiretroviral therapy. Step 5, follow-up testing. Follow-up 7 days, 14 days, 28 days, and after 12 weeks after starting PP. Monitor for the acute seroconversion illness within 3 to 6 weeks after exposure. Avoid, most important part, avoid the blood donation, breastfeeding, and pregnancy during when patient is on post-exposure prophylaxis. Person should use the universal precautions. Person should refrain, healthcare provider should refrain from the unprotected sexual activities. Adherence and adverse ADR counseling needed for the patient those were having uh, in a follow-up for the post-exposure prophylaxis. This table shows the timing, mainly weeks timing of follow-up, week 2 and week 4. Person taking PP, you have to do the complete blood count, serum creatine, fasting sugar. Then mainly fasting sugar is done for patient those are on dolutegravir based regime. Dolutegravir has effect known tendency to raise the blood sugar level. Uh, at the 6 weeks, 12 weeks, and 24 weeks, HIV testing is done, and the testing is done as per NACO norms by using three tests. Care pathway, mainly assessment, clinical assessment for assessment of exposed person, first step, eligibility assessment for post-exposure prophylaxis, HIV testing of exposed people and source if possible, provision of first aid in case of broken skin and wound. Second most important step is counseling and support. You have to explain the risk of HIV, risk and benefits of PEP, inform about the side effects, enhance counseling of post-exposure prophylaxis to be prescribed, specific support in case of sexual assault. Prescription PEP should be initiated as early as possible following exposure. 28 days prescription recommended for the age appropriate ARV drug. Drug information and maintaining PEP register is most important step. Follow up assessment of the underlying comorbidities, possible drug-drug interactions. HIV test 3 months after the exposure. Test for the hepatitis B surface antigen and anti-SCV. Also linked to the HIV treatment if necessary. When anytime during follow-up, if that person, exposed person, found positive, at that moment you have to link that person to the HIV treatment if it indicated. Provision of the uh, prevention intervention as appropriate. Availability of PEP drug. PEP drugs required on urgent basis, accessible around the clock. In our institute, we keep the PEP drug available at many spots, mainly in casualty, in MICU, which is nearby to the OT, uh, labor room. PEP drug, so that a person can take the first dose as soon as his exposure status and exposure status and source code is assessed and PEP eligibility is assessed by the physician. The exposed person should go to the designated clinical officer at the earliest for complete risk assessment and HIV counseling testing and PEP. All hospital staff member must know whom to report for PEP, where PEP drugs are available. And regular checks should be made on expiry dates, replacement of expiry drugs which are kept for the post-exposure prophylaxis. PEP cases should be documented in an accidental exposure from the and has to give the informed consent form. PEP register reporting drug consumption should be done in a software. Now, post-exposure prophylaxis is the second best approach to occupational exposure to HIV. Then, what is the first base approach? First base is always prevention. Prevention of HIV exposure is the most important and first approach to avoid the HIV infection. Mainly, you have to stick to the universal precautions and proper use of personal protective equipment. Primary prevention mostly avoid occupational exposure to the blood and body fluid and potentially infected material. No recapping of needle, because most of the time post occupational exposure in a healthcare setup occur due to the recapping. And standard precautions is the prevention, and it is the most important key toward the preventing the infection. Mainly always use the protective gear. Consider all blood specimen as infectious. Follow universal precaution while doing the uh, any in vitro procedure. Safe handling of the shafts by using kidney tray. Kidney tray has its own importance. Most of the time, when you handle the shaft without kidney tray, it leads to the uh, sharp injury or needle stick injury. And use of needle destroyer, now this use of destroyer is not recommended as per NACO or ICMR guidelines. You have to use the sharp container. Accidental exposure to the blood and notification. This is a format which notify the accidental exposure to the potentially infected blood. PEP informed consent form. This is a format for the PEP informed consent. You have to inform the details about the risk. You have to inform duration of post-exposure prophylaxis. You have to inform the side effects of the drugs, and you have to give the informed consent. Take the informed consent from the patient or exposed healthcare worker. This is the format for the PEP register. You have to keep this register either at ICTC or ARTC. If you are having both, you have to maintain this register at the both ends. Key points of today's session: mainly make HIV transmission to a SCP minimum by following the universal and standard precaution. Implement universal work precaution plan in facility. Consider all patient samples as a potentially infectious. And PEP or post-exposure prophylaxis for HIV should be started within 2 hours. If not possible, preferably within 72 hours. Never delay due to unavailability of source status. Documentation and reporting of each injury uh, or exposure is essential. Sensitizing healthcare providers and accessibility of PEP round the clock is most important thing. Person exposed to the risk of transmission of HIV, but also he or she or healthcare provider has more risk to getting infection with hepatitis B and hepatitis C. Thank you. This is all.